Broken communication is responsible for 70% of patient harm. So, when the communication breakdowns occur, a lot of the time that is at handoff, whether one doctor is reporting to another doctor or a nurse is changing shifts and one's going home and one's coming on. There are information that drop through the cracks that don't get conveyed to the other person.
Welcome to the Cast. We'll bring you all things science, engineering, technology, and innovation. Today we are joined by Dr. Julie Siemers, a patient safety expert with over 4 decades of experience as a trauma flight nurse, CU nurse, a nursing dean. She has dedicated her career to fixing what she calls the broken system inside hospitals that lead to preventable patient harm. She is a founder of LifeBeat Solutions and the author of Surviving Your Hospital Stay. In this episode, we'll analyze healthcare as a complex system, drawing parallels to engineering and exploring how better designs can save lives. Dr. Julie, welcome to the show.
Thank you. I appreciate being here.
Yeah, I'm excited to have you here as well. So, your career spans 4 decades, from the trauma helicopter to the ICU to the dean's office. What was the pivotal moment or series of events that shifted your focus from direct patient care to becoming a dedicated patient safety expert and educator?
Yes, as you mentioned, I spent 30 years at the bedside taking care of patients in various departments as well as on the helicopter. And then I transitioned into nursing education in 2009. And that's when I started researching my thesis and chose the topic of patient safety because I found that it wasn't really talked about in the healthcare setting, and between healthcare providers, we just don't talk about it. So the more I researched it and then continued on in my doctoral studies, finding that patient harm through the medical system was the third leading cause of death, that's when I decided I needed to take my experience and take my education and step up to help both nurses with their gaps in their education and then patients and their families also. They must be an active participant in the healthcare journey because of all the various ways that harm can occur. So we need to be in this together.
Oh, interesting. That's quite fantastic journey. So, you've said that most harm isn't caused by bad people, it's caused by broken systems. But for our audience of engineers and systems thinkers, what does a broken system in a hospital actually look like from the inside? And can you give us an example?
Sure. So broken communication is responsible for 70% of patient harm. So when the communication breakdowns occur, a lot of the time that is at handoff, whether one doctor is reporting to another doctor or a nurse is changing shifts and one's going home and one's coming on. There are information that drop through the cracks that don't get conveyed to the other person, even with electronic health records or even the old fashioned paper records. It's easy to not find all the pertinent data that really is going to impact the patient care. So, communication breakdowns is probably the biggest area of contributing to patient harm. Again, between healthcare providers, but also I put family members in that bucket because they can see the nuanced or subtle changes that their family members are going through in the hospital that healthcare providers don't know that patient as intimately as their family members do. So I may see my mother and go, she's acting confused. This is new for her. This is not her normal. Whereas a nurse may see a patient who's my mother's age in their 80s and say, oh, well, they're just old. They're going to be confused. But if we understand that it's new, then we need to find what's going on, Why is this patient, are their electrolytes abnormal or their blood glucose or their oxygen levels? So, again, that patient's family has to be a part of the healthcare team in ensuring that patients get the best and safest care to have good outcomes. That's a big one. Um, I'll give you another example where a patient went in for surgery for a brain tumor and was told after surgery by the doctor that don't worry, it did not look cancerous. It looked like it was benign. Well, the actual pathology report got lost, and the doctor never saw the actual positive for cancer report. And so the family members didn't ask for the report either because they assumed it was not cancerous based on what the doctor said it looked like. So that's an opportunity to say we have checks and balances that we need to be better at. And I say in this regard, the doctor should have looked for the result, didn't. Maybe they got really busy. The family should also know that they should ask for the results. Again, it's closing the loop that things don't fall through the cracks. So that's one really big area in the healthcare system.
Wow, that's really insightful. Your experience as a flight nurse is incredibly intense, in my opinion, requiring rapid, high stakes decision making. So, how did that environment teach you about the importance of clear protocols and communications, lessons that apply to any complex system?
That's a really good question. You're right. It's the most intense area that I've ever worked as a nurse. Surgical ICU or the trauma center were both high acuity, very sick patients coming in the doors, but we always had a physician, a surgeon, an anesthesiologist right there by the bedside when we needed them. Versus in the helicopter, my paramedic partner and I would be flying out to places that did not have hospitals or had a lower level of care. Maybe they had a physician assistant in a clinic and had a patient having a stroke or having a heart attack or a trauma victim. And we had protocols in our little pocket book, that had been approved by our medical director. But for so long working in the intensive care and the ER gave me the flexibility of learning how each patient is different and how we need to understand the basics of, is this patient alert and oriented, or are they confused, do they have a head injury? And so there's a process of working down the patients, from the most critical gaps in their stability, clinical stability, to figuring out how sick or unstable they were and understanding what the priorities were before we would either take the patient into the helicopter, because inside it's limited space and it's a little more challenging to do some procedures. So, to give an example, airway and breathing, that is the absolute priority with a patient, that we must make sure that they have an intact airway and can breathe. And then circulation, of course, with the heartbeat. So, every patient was different. Every patient was challenging to some degree or the other, but I loved the autonomy. I loved leaning into my years of experience and practice and knowing that we had a medical director who trained us well, a chief flight nurse who trained us well, and just did the best that we could given the circumstances.
Amazing. So, from an engineering perspective, healthcare is a highly complex adaptive system. So, where do you see the biggest gaps where technology or better system design could most effectively prevent the hidden risk of hospitalization that you often talk about?
I think one of the opportunities that we have currently to improve healthcare right now, because of the electronic healthcare systems, the electronic healthcare records, the physician and nurses are both spending multiple hours trying to document care, which takes them away from the patient's bedside. The solution that I see that would be wonderful is a voice activated recording that goes into the patient's chart. For example, if I were taking care of a patient and I'm changing their dressing, I could speak right into a microphone on my lapel, perhaps, that said, "Okay, I'm in Mr. Jones' room in 503B. I am changing his dressing. I see the wound is pink. It's healing well. The tissue is granulated," or whatever description I want to give. The rest of his skin looks good. We can speak as we're doing care, and same with physicians. And then the technology would have to get that into the patient's medical record so that anyone following behind can see, oh, well, yesterday the wound was pink. Now today it looks a little like maybe it has some drainage that we need to take a look at. So I think there's so many opportunities for technology to assist the human taking care of the patient. And I think AI's got some amazing opportunities to help us with that too. For example, taking pieces of data that we would program it with, for example, the white blood cell count, the patient's temperature, and some data points that we would look for as a human to say, oh, it looks like they may be getting an infection. And then we can say, do we need to start the sepsis protocol? So we would get those red flags of, hey, you need to go check on this patient and dig further into the data to see what's going on.
Well, that was a really great response there. So, I'd like to ask, you've spent 15 years in nursing education. So, what is the most critical skill or mindset that you strive to instill in new nurses to help them become effective safety advocates within the system?
That's an excellent question. I would say that teaching nursing students clinical judgment, which is a process because number one, first they have to have the foundational knowledge, such as anatomy and physiology, for example. If the students understand the normal physiology of, let's just say, the difference in oxygenation and ventilation, when we inhale and we take in oxygen, that oxygen goes through our blood cells and into through our lungs. And then we exhale the carbon dioxide. So it's a very efficient process. But if the nurse doesn't understand the levels of carbon dioxide and oxygen based on a patient's respiratory rate, for example, because if they're breathing faster, they're blowing off or exhaling more carbon dioxide. And why that makes a difference is because then we know that the cells are not getting enough oxygen. So when we understand the foundations of how the body works normally, then when the patient is in an abnormal state, then we can dig deeper and say, what else is going on here? Why is the patient breathing so fast? Is it the automatic response that the cells need more oxygen? And then what happens to the carbon dioxide? So we look at it from the perspective of what treatments we're giving the patient, and what interventions we need to do to restore the body balance or homeostasis. So, thinking the ability to take that knowledge and apply it to the patient. It's one thing to memorize electrolyte levels or the way the Krebs cycle works, for example. But where you really apply it is to looking at the patient and saying, hmm, they're paler than usual. That should trigger the nurse to go say, I wonder what their hemoglobin and hematocrit levels were this morning on their blood draws. And then we see, oh, it's dipped from yesterday. I wonder what's going on. And perhaps they had surgery. Well, maybe they're bleeding internally. And so it's really, I tell my nursing students, it's like playing Sherlock Holmes or private detective. You've got to take the pieces of data on that particular patient and then understand what other data or pieces of information you need to collect to paint the picture. And I always explain to the nurses, the students too, that your patient is on a continuum. Here's healthy on one side, which we don't really have healthy patients. And on this other side, your patient is critically ill or dead. And so the patient is moving on that continuum throughout the time that we're taking care of them. And it's our job because we, as nurses, spend most of the time at the bedside as compared to a physician, right? A doctor comes in for a couple of minutes and then they're out. And so that understanding the physiology, how it applies to this patient, what their medical history is, what they're complaining of, helps us paint that picture to understand whether they're critical or becoming more stable, which is our goal. Does that make sense?
Yeah, it sure does. That was a wonderful response there. So earlier in this conversation, you talked about how communication breakdown uh, can be a common factor in errors. So I'd like to ask, what does effective human-to-human API look like between a patient, their family, and a busy healthcare team? What are the key data points that need to be exchanged?
That's a perfect question because I do speak a lot about this because I think it's highly relevant to keeping patients safe and having that open communication. Many times in the US, at least, patients and their families are afraid to speak up to the doctor because we still live in a hierarchical society where, because the doctor has had 12 years of medical school and training, and the nurses have 4 or 5 or 6 years of training, that the family and patients many times think, well, what do I know? They're the experts. But I have to say, we must have a healthy skepticism and not take everything at face value and get involved in the healthcare and learn. I'm not saying you need to become a nurse or a doctor, but if you can learn what's normal for the surgery your mom and dad or are having or their disease process, what is normal, what is not normal, then you can step in and advocate because when patients get sick, they don't have the capacity, the mental capacity or the physical capacity sometimes to remember things or to report everything. And that's where family can come in as so essential. So, to fully answer your question, I believe that we need to create this bridge between healthcare providers and patients and their families where there's open and two-way communication, where patients and families aren't dismissed, but yet listened to, and patients and the families have the courage to, or knowing the reason why it's so important for them to share what they know or what they observe and what they see with their family members.
So your work empowers patients and families to be active participants in their care. So, what's one simple but powerful question that anyone can ask their nurse or doctor that can significantly improve their safety?
One thing I would start with is, what is the priority here? Whether you went in with your dad because he can't breathe or whether he is having surgery, what is the priority and what are we hoping to accomplish? And then the next question would be, how can I assist and what can I watch for so that I can tell you if the signs of becoming unstable are apparent? And I think that collaboration, when you ask those kinds of questions to the healthcare team, then it shows them that you want to help and that you want to partner. Another really important question is, what medication are you giving my dad? Because medication errors cause so much patient harm. They can be the wrong medication, the wrong dose, the wrong time, the wrong route. And these are all the things that the nurses learn in school. We call it the 5 rights of medication safety when they are supposed to check the name band. And some places have the barcode scanner. So they scan the medication, they scan the patient's armband. Not everybody, not everywhere has one of those, but it's taking those extra steps and make sure that they check that your family member, if they have an allergy, that there's a band on that says allergic to penicillin or allergic to morphine. Because again, every patient is different. But the more we get involved and the more we just ask questions from a place of curiosity and not trying to do the healthcare team's job, but to be there to facilitate a better outcome for the patient.
So, having worked at all levels of healthcare, from the bedside to executive leadership. What is the single biggest cultural or structural barrier to implementing lasting safety improvements?
I honestly believe the best way that we're going to be able to improve patient safety and change the numbers in a positive direction, number one is awareness, and number two is transparency. So we must talk about what is going on and where there is near misses. We call it that in healthcare when, let's just say, a nurse almost gave the wrong dose of a medication because the vial looks exactly the same. This happened to Dennis Quaid's premature twins years ago, but they were overdosed with a blood thinner because the vial with 1 to 1,000 concentration of heparin, the blood thinner, looked exactly the same as the vial with 1 and 10,000. And so the babies got way more of this medication blood thinner than they should have. Luckily, they did survive. So I think when we keep it secret, nobody else can learn from these accidents or mistakes. And we're human, we're going to make mistakes. And sometimes, again, we go back to the systems error. If the nurses have too many patients and they can't take their time because they're rushing to do so many tasks to take care of the patients, they may miss doing a medication safety step. That happened not too long ago. I made a social media post about this where the nurse hung the wrong medication and the patient ended up dying. And so it's skipping the safety steps that I call a systems error, also. And I think when we really can be truthful about it and share. We don't have to share people's names that made the mistake. That's not the point. The point is to say, this happened here. It could also happen where you work. And we just don't have the platform to do that. We don't share very much. We don't hear about patient harm events that occur. And therefore, I think that's one of the biggest contributors to the repetition of systems errors that lead to patient harm.
Okay, so I'd like to ask for the innovators listening, what's a patient safety problem that you believe is ripe for a technological solution that hasn't been adequately addressed yet?
Well, we've had a lot of really good technological advances that really benefit patients. One of the biggest problems that I hear about today is alert fatigue. So, for example, if a physician puts in an order in the electronic medical record for a certain medication, or a nurse goes to give a medication, there may be, I've heard one study that said up to 80% of the alarms that or the alerts that come across when they get into that area of the patient's chart are insignificant. So when we have alert fatigue or even medical devices with alarms, alarm fatigue, we get desensitized and we ignore them. And then the reason that they were there to begin with is to keep patients safe. But if we're hearing, the old story of cry wolf 100 times, the next time there really is a wolf, you're not going to notice it because you're like, oh, here we go again. And so, for example, the nurse that gave them wrong medication out of the automatic dispensing cabinet at Vanderbilt Hospital several years ago, there was warnings on the screen, caution, and they had gotten so used to just ignoring all of the warnings in their haste. So if we could develop a program to decrease the insignificant alarms or insignificant alerts, then the really important ones we're going to pay attention to, and that would, I think, contribute to many more patient safety events, not harm events.
Wow, that's so much insight packed in a single response. So I'd like to ask, how has your perspective on risk and error prevention in healthcare evolved over the time?
Mm. Well, I wish I could answer that we are improving. and we are a tiny fraction. I think the data reported that a decade ago, 27% of the patients that went into the hospital had some kind of harm event. And I think the most recent data said that we're down to 25%, but that's not moving the needle enough. That's still 1 in 4 patients that suffer some kind of harm in the hospital. Um, for example, delayed or missed or wrong diagnosis account for almost 800,000 people every year ending up with permanent disabilities or death because of the diagnosis delay, or just like the brain tumor example I gave earlier. Maybe that man would have lived had that report not got misfiled. Maybe he would have got chemotherapy and radiation 6 months sooner, and maybe it would have saved his life. So I think while we may have improved fractions, we have much further to go to make healthcare safer for patients. I can tell you, it doesn't matter where in the country I live. If one of my family members goes into the hospital for something serious, and that's pretty much everyone that goes to a hospital and stays in a hospital nowadays is serious, the acuity is pretty high, I would not leave their bedside because there's just so many opportunities to make a mistake, which is really sad to say. Healthcare should be one of the safest places on the planet, but it just isn't set up yet to a place where, oh my gosh, thank goodness they're going to this hospital, they'll be safe. I do want to add one piece here if I can. What I would love to leave for your listeners is a website. It's called hospitalsafetygrade.org. And you can go on, put in your zip code. This is just US hospitals. And you can see all the hospitals in your area and how they're ranked for safety. So there's 5 main categories and subcategories. And with these 32 different areas where they're ranked red, yellow, or green, they're doing really good in this area, or they need improvement, or they're got a lot of improvement they need to do. So those 32 categories will add up to the hospital ranking. They do this twice a year. It's nonprofit and it's all research data, but the hospitals rank anywhere from an A through an F. I would never go to a D or F rated hospital. In fact, I'd be really careful and cautious to go to a C ranked hospital. I would definitely pick an A or B, whatever area you live in and what's closest to you. I would even drive further to get to a higher ranked hospital because, again, I can see in that on that website if they've got high rates of Clostridium difficile infections or high rates of MRSA infections, or they've got high rates of blood clots that occur with patients after surgery, or breathing problems after surgery. So those are areas where hospitals can really integrate improvements with their teams to make it a safer experience for patients.
Okay. Well, I have to thank you for sharing that information. I think that was very, very valuable. You have to know the standard of an hospital before you actually go there. I think that was a really great one you shared with us here. So I'd like to ask, looking at the future of healthcare, what gives you the most hope that we can build safer and more resilient systems for both patients and staff who actually care for them?
Yeah, you bring up a really good point because we know after COVID that many healthcare workers were extremely burnt out because of the stress, emotionally exhausted, physically exhausted. And I have to say, even though it's been 5 years, the recovery was pretty slow. So that definitely impacts the patient's journey through the healthcare system. But I think we need to stop for a moment and say that every healthcare worker and every patient is a human being, and we don't know what they're going through. We don't know what their challenges are. And if we can look at each of us, whatever capacity we're in, as a human that really cares, because most healthcare providers really care, and patients definitely want to um, get better, and healthy again. But it really is compassionate human care that I think is so important. And sometimes it gets a little difficult when you're in the hurry up and do this, and then you've got to hurry up and do this, going patient to patient as a healthcare provider. But understanding the way I like to look at it too and teach my students is every patient in that bed is somebody's mother, somebody's brother, somebody's father, somebody's sister. And that, sometimes if we're feeling a little disconnected from the humanity, is if we just remember that piece of stop and pause for a moment and remember, I just have a different role today than I did before. And, I always say to my students, when you're having a bad day, you got to leave it home because the patient in the bed is having a worse day than you.
Oh wow, that's really brilliant. So, what does innovation mean to you, or the word innovation? What does it mean to you, and how does it relate to your work, your life, in the context of, in context of healthcare and designing, safer systems?
Yeah, that's a really good question. And I think for me, I've innovated my role as a nurse as I've gone through my journey. Um, and it's brought me to the point here and today. I started my business almost 2 years ago. I started out creating courses for nurses, which is what LifeBeat Solutions is, to fill the gaps because there's nursing school is like drinking from a fire hose. There's so much that the students really are challenged in figuring out, okay, we just talked for 3 hours on this topic, but what is the most important things I need to know and need to remember? Because they're not gonna remember it all. So that's why I created those courses. And the innovation part, I think, is really important because we have to stop and consider, what is it that we know? What is it that we are curious about? How is it that we really want to expand what we've currently done and stretch ourselves to make a bigger impact or to make the world a better place? And I think now what I'm working on, now that my courses are finished, I have 35 of them. What I'm working on now is an app for patients and their families. So I've taken the chapters out of my book and condensed it down to 6 modules or courses on how do you prepare for surgery? What if you're the family member and you're waiting for your husband to come out of surgery? What should you watch for? What should you ask the surgeon? All of those things that help. My goal is to inform, empower, educate, and empower. So taking that knowledge and even knowing that you should ask the question, hey, my dad's not looking right. Can someone please assess him? That is your right. And you should do it because that may make the difference between, further clinical instability or the nurse coming in and say, oh, yeah, we need to do something. So it really is the innovation part for me is how do I encompass what I've learned and how can I apply that to help people as well as the healthcare teams?
Oh, that was a fantastic one there. So, finally, Dr. Julie, for our listeners who want to be prepared and empowered, where's the best place for them to learn more tips from you and better safety protocols and how to interact with healthcare workers in the hospital? Are there any ways they can contact you or get resources from you?
Sure. I have my website. It's drjuliesiemers.com. That's Siemers. My social medias are also Dr. Julie Siemers on TikTok, on Instagram, on my LinkedIn. It's Julie Siemers. And so I write articles, I write blog posts, I do probably social media posts 6 times a week to give tips and stories about, what's going on with patients. My book is on my website or it's on Amazon, and the app I'll have announced probably within the next, month on my website too, as soon as that's up and ready.
Wonderful, Dr. Julie. It's been a really insightful conversation with you, and I am excited to have you on the show today.
Thank you. I appreciate being here, and I hope your audience learned at least a thing or two to help them help their family members and stay safe.